physician should know about, regardless of his specialty, because this is something that happens frequently, especially in cases of trauma and accidents and so on. So we're going to talk about brain edema and the intracranial pressure. These are two things that overlap frequently. Now, the definition of brain edema is accumulation of extracellular fluids, regardless whether it is in the periphery, in the arms, in the feet, and so on. That's edema. It's excessive accumulation of the extracellular fluid. However, in the central nervous system, it results in elevation of the intracranial pressure, and we will talk in details about that. And that increase will impair the neural function, and brain edema is potentially fatal if it is not handled correctly. Now, it is usually classified into vasogenic and cytotoxic edema. There are other types. We're going to briefly talk about them. But the vasogenic edema is the extracellular accumulation of fluid from disruption of the blood-brain barrier. And we talked about blood-brain barrier. We'll repeat that today. It leads to extravasation of the serum fluids and proteins inside the brain parenchyma. While cytotoxic edema, instead of being extracellular, it's intracellular. So there is cell swelling caused by accumulation of fluid inside the cell. What are the consequences? There is a reduction in cerebral blood flow, and we'll see why that happens. And that leads to hypoxia and irreversible impairment of the neural function, and pressure on specific parts of the cerebral tissue may lead to what we call herniation, and we'll speak about what herniation means, and frequently it may lead to death. Vasogenic edema, which is the most common, what are the precipitating factors? Head trauma is one of the major precipitating factors in car accidents, in falls, and so on. It may lead to swelling of the brain due to disruption of the vasculature. The presence of a tumor or an abscess, sometimes malignant hypertension may lead to what we call hydrostatic edema, where the pressure inside the vessels will force the fluids outside the blood-brain barrier. Infections such as meningitis or abscesses and so on, and high-altitude cerebral edema may also happen in rare instances in people who climb mountains. Vasogenic edema occurs when there is disruption in the blood-brain barrier by inflammation, by some toxic agents that may be damaging to the endothelium of the capillaries, and if there are abnormal capillaries, such as what happens with neovascularity of tumors. The tumor grows faster than the formation of properly lined vessels. So the vessels do not have proper lining inside of them, which we call endothelium. In malignant neoplasm, this happens and lead to leakage. So leakage of protein and fluid into the interstitium, which is the parenchyma, leads to swelling of the parenchyma. Plasma filtrate will accumulate, and it will change the ionic balance and impair the function of the neurons. This is a repeat of what we talked about, the blood-brain barrier. We have the blood vessel here, and it has the red cells, it has the plasma, it has the nutrients inside of it, which is the glucose, the proteins, and so on. Now, the endothelium of brain capillaries is different than the endothelium in other parts of the body, in that it has tight junctions here. So tight junctions prevent the leakage of fluids or plasma from the endothelium. The second layer of protection is the basement membrane, and the third layer is the food processes from the astrocytes, and sometimes it's called podocytes, they cover the basement membrane. Anything that the brain needs from the circulation to come inside the brain has receptors, has transporters, has some proteins that will carry it through the endothelium into the food processes and then into the parenchyma of the brain. What's the noise about? Okay, so the vasogenic edema. We have the endothelium here, and we have the albumin and plasma here, and this is the blood vessel. If there is an injury by inflammation, by oxidative stress, by glial activation, or by physical impact like in brain trauma, then we get some disruption of the blood-brain barrier. These tight junctions will open up, and then there is extravasation of the fluid and serum through the defective blood-brain barrier. How do we see that on the MRI? First of all, let's look on the right-hand side, and we find that this is a mass lesion here, surrounded by white. White in the flare means that there is excessive fluid. So this white and this white here is excessive fluid. Now, when we have T1 weighted image and we give gadolinium, the gadolinium will make the metastases or the tumors give some enhancement. Here we have some enhancement surrounding the mass lesion. And then we have this dark stuff here, dark stuff here. This dark lining is in T1 is fluid. So we have it is dark on T1 and it is white on T2 or on flare. Similarly, we have the same. The edema here is shown by this yellow arrow, while the enhancement, the gadolinium enhancement around this abscess is shown in the white ring around the abscess. We have the white ring around the abscess here, but we have the flare shows us the edema in white. So this is the edema in T1, this is the edema in T2 imaging. We go to this cytotoxic edema. Cytotoxic edema is an intracellular phenomena. It happens with hypoxia, if the patient is exposed to cardiac arrest with hypoxia, if there is occlusion of an end artery like middle cerebral artery, then we have deprivation of circulation and oxygen from the area or the territory that is supplied by the middle cerebral artery, which causes infarction, what we call a stroke. Sometimes with near drowning or strangulation, also there is some hypoxia. Toxic substances that impair the sodium-potassium pump, some toxic drugs, or impair the production of ATP, adenosine triphosphate, like in cases of mitochondrial damage, either congenital mitochondrial disease or substances that are toxic to the mitochondria. So what happens in cytotoxic edema? Here we have a normal astrocyte, and we have the sodium outside and the potassium inside. If we have ATP depletion or mitochondrial dysfunction or oxidative stress, what happens is that this pump that keeps the sodium out and the potassium in will be disrupted, and you have influx of sodium inside the cell. That leads to the swelling of the cell, and that swelling will eventually lead to change in the osmotic pressure, and there is outflow of the intravascular sodium and fluid because of the imbalance of sodium in the extracellular space. Precipitating factors, as we talked about cerebral ischemia, this is a dense middle cerebral artery clotted, and that's why it is shown dense. Sometimes hemorrhage, sometimes liver failure, such as what happens in young children as a toxic effect of salicylate. They get Rye syndrome, severe hypothermia, and cardiac arrest, which happens frequently in intensive care units. MRI shows us cytotoxic edema in an infarction, both on T2 imaging and on diffusion-weighted imaging. Diffusion-weighted images has the advantage of showing it only at a certain period of time, which is about from the occurrence of the edema or occurrence of the cytotoxic edema up until 1 month, and then it disappears. The T2 imaging measures the transverse relaxation time of the excited protons, and the signal intensity is related to the increase in the vascular permeability. While the shown on the right-hand side, the diffusion-weighted image in an area of infarction that shows reduction in the ADC values. We'll see what the ADC values is shown, but here in the diffusion-weighted, plain diffusion-weighted, it will be high signal. Similarly, we have the parietal infarction here. We have the T2. It is a high signal because it's accumulation of fluid. And then we have the diffusion-weighted image, which shows, look at the cortex here. It's outlined. This is cytotoxic edema because the swelling is inside the cells that make the cortex, the neurons that make the cortex. So these are damaged neurons by hypoxia. This is what we call the ADC map. ADC stands for apparent diffusion coefficient. They all measure how the fluids are exchanged. And if we see the cortical ribbon here, we can see that it is dark. We have this dark stuff on the cortex. We have this dark stuff on the cortex. So this is a cytotoxic edema shown on MRI, diffusion weighted and diffusion coefficient. Other types of edema include interstitial edema. As the name implies, interstitial means that it is in between the components of the tissue. It happens usually with obstructive hydrocephalus that leads to leakage through the ependyma, that the ependyma will filtrate some of the fluid that is inside the ventricles. And that is a disruption, not between the blood-brain barrier, no, it is the CSF-brain barrier, because the CSF is inside the ventricles. It is outlined by the ependyma. The ependyma becomes stretched under pressure, so it will start leaking the fluid. There is the osmotic edema that happens sometimes in patients who undergo dialysis, where the electrolytes in the brain becomes at a certain period of time higher than the electrolytes in the serum because they were taken out by dialysis. Then that osmotic gradient will cause fluid to migrate inside the brain and cause brain edema. And then there are some mixed types of brain edema. This is the interstitial edema. As you can see, the ventricles here are large. They are ballooned, so intraventricular pressure is high, and the stretching of the ependyma causes them to leak fluid inside the interstitial tissue of the brain, and it is shown on this T2 weighted image as white cap on the ventricle. Again, this is another hydrocephalus showing us in T1 transependymal edema. On T1, as I mentioned before, the edema is dark gray. It's dark gray here. While if we look at FLAIR, it becomes white because FLAIR gives us a T2 weighted image. It is called FLAIR because although this one is T2, but the signal that comes from the ventricle is attenuated because inside the ventricle is fluid, and FLAIR stands for fluid attenuated inversion recovery, which is the sequence that this was filmed at. So we can see the edema surrounding the ventricles because of pressure inside the ventricles. What does edema do for the brain? It increases the tissue mass, which because of the accumulation of fluid or the retention of fluid in the parenchyma. Why is this a special problem to the brain if there is edema? Because the brain is an enclosed space inside the intracranial cavity, and there is no lymphatics to drain the brain. The brain drainage goes outside through the CSF reabsorption. So we look at the contents of the intracranial contents. We look at this part, and this part is the cerebrospinal fluid, this thin line in the subarachnoid spaces, and it constitutes about 10% of the content of the intracranial cavity. And we have the blood vessels. These are arteries. Also, the blood vessels are the veins. Arteries and veins carry about 12% of the intravascular blood carries about 12% of the intracranial contents, and then the majority of the content is brain tissue, which is 78%. So we talked about the parenchyma, the CSF, and the intravascular blood. An increase in any of these three components will increase the intracranial pressure, and the clinical hallmarks of the raised intracranial pressure are headache, vomiting, and if we examine the patient, we see swelling of the optic disc, which we call papilledema. There is a doctrine which says that the intracranial cavity is limited. It is surrounded by hard, unrelenting bone, and we have the three components that we talked about: brain, blood, and CSF. How is the intracranial pressure maintained? If the volume of any of the three components increases within the intracranial vault, the volume of other components should be displaced. The total intracranial volume will not change if we displace it. So if we look at this, we can see that if something that is added inside the brain, the pressure goes high a little bit until it reaches a critical moment, then it is exponentially going high. Why? Because at this time there is compensation. The fluid, the CSF fluid may be reduced, the blood volume, intravascular volume will be reduced, but these constitute only about 20% of the, if we remove them all, you gain only about 20%. If the added mass to the brain is more than that, then we get exponential increase in the pressure. Cytotoxic versus vasogenic edema. In practice, swelling most of the time is caused by both mechanisms, cytotoxic and vasogenic, but the treatment is different. If it is vasogenic edema, then we can try to draw fluid from the parenchyma of the brain by giving high hypertonic solution, such as mannitol, which is a polyol, which is something like a non-digestible sugar, or we can give 3% saline, which is a high concentration saline, to draw water from the parenchyma of the brain into the vascular bed. Normal intracranial pressure is about 5 to 15 millimeter of mercury, or about 15 to 20 centimeter of water. The increase may be due to tumor growth, maybe due to accumulation of edema fluid, maybe due to the excessive accumulation of cerebrospinal fluid, such as what happens in hydrocephalus, or due to added blood within the parenchyma, such as what happens in intracerebral hemorrhage. How does the intracranial pressure progress? The only way to relieve it is, as I mentioned, to remove part of the other components. The most readily displaceable is cerebrospinal fluid. If the intracranial pressure is still high, then cerebral blood volume will be reduced. So we are in stage 1, where there is vasoconstriction and external compression of the venous system, and it is a compensating. So at that time, there are few clinical symptoms. But if the intracranial pressure continues to increase, it may exceed the brain's ability to adjust for that pressure. Then the pressure will be increased in a stage 2. There will be a decreased oxygenation of the tissue because we already reduced the blood flow, and there will be some systemic vasoconstriction to try to push as much blood across the resistance of the brain. And the clinical manifestations will be confusion, restlessness, drowsiness, sometimes start to have pupillary changes or breathing changes that we talked about when we talked about coma. Now the third stage, when the intracranial pressure comes near the mean arterial pressure, then we are beginning to decompensate. There is hypoxia and hypercapnia, which leads to cytotoxic edema. And then there is decreased level of consciousness, there is stupor, then leads to coma. The pulse pressure, the peripheral pulse pressure will be increased. Instead of being 120/80, we will have 160/70. So you have increase in the pulse pressure, the difference between the systolic and diastolic. May begin to have Chine-Stokes respiration that we talked about when we talked about coma. There is bradycardia, or increased pressure in the carotid arteries, and the pupils become small and sluggish. At this time, this is the time for surgical or medical intervention, either by mannitol or by decompressive surgery to remove whatever it is, if it is a hemorrhage and or if it is hydrocephalus. Stage 4, when all compensatory mechanisms have been exhausted, then we have high rise in the intracranial pressure in a short period of time. We lose the autoregulation of blood vessels inside the brain. There will be some vasodilatation, which will further increase the intracranial pressure. The cerebral perfusion pressure will be reduced, then that leads to hypoxia, and the brain contents will herniate. Now, so this is a summary slide. Intracranial pressure, it's a medical emergency which can result from head injury, from bleeding, etc., etc. And we have the mean arterial pressure here, and we have the intracranial pressure. As long as the intracranial pressure is less than mean arterial pressure, there is circulation. If it goes above that, then it will shut down the circulation, and that will lead to sympathetic nervous system activation and the parasympathetic activations, which will lead to what we call a Cushing triad. Cushing triad is bradycardia, decreased heart rate, irregular respiration, and wide pulse pressure. This is the Cushing triad. And this is more commonly occurs in posterior fossa, increased pressure. Other symptoms include weakness, lethargy, and so on. And the treatment, as I mentioned, you should give the patient intravenous mannitol or hyperventilate. What the hyperventilation does is that it blows out CO2. When you have low PCO2 in the blood, there is constriction of the cerebral vessels. So what you are doing, you are displacing some part of the intracranial contents, which is the intravascular volume outside the brain. So you can gain with hyperventilation. All of these are temporizing measures. They work for a limited period of time. The hyperventilation will work for a few hours. Mannitol may work for several hours. It will give time for any more definitive measures, such as surgical decompression. So in the final stage, which no one wishes to reach, there are small hemorrhages in the brainstem, and the pupil at the site of herniation will be dilated and fixed. And as I mentioned, when the mean arterial pressure is equal to the intracranial pressure, the blood flow to the brain stops. So what happens is that we get into what we call a downward spiral. It starts either with neuronal injury, such as with hypoxia, or decreased intracranial blood flow. What happens is this way. You can start this spiral from any part. Let's say that there was some increase in the intracranial pressure to start with. So it reduced the intracranial blood flow. Then there is neuronal injury and cytotoxic edema, which swells the neurons and the astrocytes, and then swelling of the neurons and astrocytes will increase the pressure again. So you start having a spiral that doesn't stop. And when intracranial pressure is above the mean arterial pressure, this is incompatible with life. Herniation, we've talked several times about herniation. Herniation happens if there is a mass lesion on certain part of the brain. This is a normal diagram of how the brain is seen. This is the cranium, and this is the brain structure, and this is the cerebellum, and this is the tentorium that separates the anterior cranial fossa from the posterior cranial fossa, which houses the brainstem and the cerebellum. Now, the brain connects with the spinal cord through what we call the foramen magnum. What happens if you have a mass lesion? It will exert pressure on the surrounding brain. That's why the ventricle becomes more collapsed. The midline becomes shifted, and there is some downward displacement. This is what we call the herniation of the temporal lobe inside the tentorial notch. And the compression of the opposite, this is important to remember. Now, we have the midbrain and the cerebral peduncles. These cerebral peduncles carry the pyramidal tracts, carry the corticospinal tracts. If the pressure is pushing the brainstem against the sharp edge of the tentorium, it will cause compromise of the cerebral peduncle or the corticospinal tracts that are inside the cerebral peduncle. Then what we have a false localizing sign, because this corticospinal tract will finally decussate and supply the other side of the body, which is the same side where the lesion is. So we find a Babinski sign on this side, and we think that the lesion is here. No, the lesion is here, and the brain content had been shifted, and this was pushed against the edge of the tentorium. Now, there are 4 types of herniation syndromes. Number 1 is the subfalcine or the cingulate gyrus. We call it either by what gyrus that had been herniated or the location. This is the falx cerebri, and this is the subfalcine herniation, which means that the cingulate gyrus will move underneath the falx cerebri. The number 2 is the transtentorial, which we call uncle herniation. Uncle, because the first thing that will herniate is the uncus of the hippocampus. So we call it by the structure that had herniated, or by the space that it's herniated through, which is the tentorium. Now, sometimes if there is a single lesion, then the herniation happens on one side, on the side of the pressure that is created by the lesion. But if there is a whole brain swelling, then we get what we call a central herniation, where both hippocampi will herniate through the tentorium, which is more serious problem. Number 3 is the foraminal or tonsillar. Again, the area from which it is herniating is the foramen magnum, so we call it foramina. And the structure that is herniating is the cerebellar tonsil. This is a dangerous type of herniation because it will squeeze the part of the medulla which houses the breathing control and may cause apnea. And the 4th type of herniation is transcalvarial. Happens during surgery. Calvarium, which is the bone of the skull, leads to moving of parts of the brain. If you do a burr hole or if you do craniectomy, then you get part of the brain, if there is pressure, to herniate through that aperture. So transtentorial herniation, what it leads to, as I mentioned, this is the level of the tentorium. If the brain herniates down, this is the basilar artery. So these feeding branches, perforators, will be stretched, and then it will lead to bleed. And as we can see here, several areas of bleed in the pons. These are called Duret, which is a French pathologist that described them. These are Duret hemorrhages. Now, in the remaining time, we'll talk about what we properly call idiopathic intracranial hypertension. We don't like to call it benign intracranial hypertension because one of the complications is loss of vision, and nothing that make one loses his vision can be called benign. Or pseudotumor cerebri, because it may give the impression that there is a tumor. There is no tumor. It is idiopathic increase in the intracranial hypertension. The symptoms, the headache is variable, but it's seen in about 90% of patients with high pressure. The patient may complain of pulsatile tinnitus, and usually it is of low frequency, like shh, shh, shh. But if you don't ask about them, the patient is so bothered by his headache, he may not volunteer such information. But if you ask about it, do you hear any noise in your ears? And then he will say, yes. Shh, shh. There is pain in the neck, shoulders, arms. They may go in the direction of nerve roots, which is called radicular pain. There might be some transient visual obscuration. Transient visual obscuration may be a late phenomenon when the pressure is high, and usually it happens with change in the posture because the pressure will cause impairment in the supply to the retinal artery, central retinal artery, because it passes through the intracranial structures. There might be some distorted vision, visual field constriction, infrequent, and diplopia, because the pressure may affect the function also of the sixth cranial nerve. Usually the diplopia is horizontal because it is the sixth cranial nerve, but this is something that we don't want anybody to reach that level, because sometimes it just closes off the central retinal artery because of the pressure and cause visual loss. The clinical signs are papilledema, as shown on the right-hand side. This is papilledema. We can see acute papilledema, which is swelling of the disc, and sometimes chronic papilledema, which is some pigmentation around the disc. We have visual field maybe either constricted, or we can find that there is enlargement of the blind, normal physiological blind spot. Visual acuity is usually not affected, but we might see, as I mentioned, sixth nerve paresis. Papilledema, the appearance is that of elevation of the disc. This is a chronic papilledema, and this is a normal sagittal cut in the optic nerve. And what we see here is papilledema. We see the disc raised. We see swollen exoplasma inside the nerve fibers that are coming from the nerve fiber layer inside the retina. And we see some venous dilatation and tortuosity. Sometimes there are hemorrhages and exudates. Sometimes we can see that there are retinal folds because the lifting of the disc will pull part of the retina, and we can see some retinal folds. When the edema is resolving, the sharp, fuzzy edge becomes less distinct. We do CSF studies for those patients. In every patient with raised intracranial pressure or suspected idiopathic intracranial pressure, the diagnosis is only confirmed by measuring the CSF pressure. You don't diagnose a person that he has arterial hypertension without putting a sphygmomanometer on his arm and checking his blood pressure and finding that it is 170/90. Similarly, you have to put a needle and you have to put a manometer and measure the opening pressure. And if it is above 25 centimeters of water, then that is raised intracranial pressure. We check the cells to make sure that we are not dealing with meningitis. We check the chemistry for protein, sugar, and electrophoresis, and we do the microbiology to rule out infection. If we do CT on a patient with benign idiopathic intracranial hypertension, we see this appearance. See, this is the nerve here, and around which the optic nerve sheath becomes swollen because the fluid will accumulate also in the sheath of meninges that surround the optic nerve. We see that in the coronal section, and we see that in the axial section. Now, there is a special situation, which is cerebral venous thrombosis. Cerebral venous thrombosis causes raised intracranial pressure, and it should be treated differently. The hallmark of diagnosing cerebral venous thrombosis on CT is what we call the delta sign. The delta sign is nothing but the superior sagittal sinus cut across, showing the lumen of the sinus and showing the enhanced walls of the sinus. This is the falx, this is the sagittal sinus, and this is the cut in the sagittal sinus. Because it is a triangle, and the triangle letter in Greek is delta, they call it the delta sign. Usually, the CT in cerebral venous thrombosis will show venous infarctions, and the venous infarctions are usually bilateral, but maybe sometimes more predominant on one side than the other. So the criteria for diagnosing idiopathic intracranial hypertension is to have clinical symptoms and signs of raised intracranial pressure. The neurologic examination is normal. There is CT scan that rules out hydrocephalus or mass lesion, so there is no tumor and no ballooning of the ventricles. And it is confirmed by measuring the CSF pressure by lumbar puncture, and CSF composition should be normal. There should be no meningitis, and venous thrombosis should be ruled out because it has to be treated in a different way. It has to be treated with anticoagulants. The mechanism of idiopathic intracranial hypertension is increased formation. These are theoretical, increased formation of the CSF, or a change in the elasticity of the parenchyma and the intracranial blood vessels, or obstruction of the venous outflow, or resistance to the CSF outflow at the level of the arachnoid granulations, and we'll see what that means. So CSF flow in a normal situation, CSF is generated by the inside the ventricles of the brain, by the choroid plexus, as we can see these dark arrows, and then it comes from the ventricles into the fourth ventricle, and from the fourth ventricle, it goes through the foramina of Luschka and Magendie, and then it circulates around the cerebellum, it circulates around the brain, and it circulates around the spinal cord. Then what happens is it goes through what we call the arachnoid granulations or arachnoid villi. Now, look at how the drainage happens. These are the levels. This is the skin of the scalp. This is the bone, the diploic bone of the skull. This is the dura out here, and this is the arachnoid, and this is the brain parenchyma and the pia. And we have the veins. The veins are both the scalp veins underneath the scalp. We have the transdiploic veins. We have the veins inside the diploic structure. And we have the veins that attach to the spherosagittal sinus or other sinuses. And we have these arachnoid villi that come from the subarachnoid space and bulge inside the vein. And when the pressure here is high, it will, or pressure of the CSF is high, then it will push the fluid inside the vein where it will be carried outside the circulation. So this is a close up. This is the subarachnoid spaces. This is the arachnoid villus. And the arachnoid villus, sometimes it gives an impression on the inner table of the skull. These are the bridging veins that we talked about last time in subdural hematoma. And whenever the pressure in the subarachnoid space is high, these villi will bulge inside the sinuses and will dump some of the fluid here, so it will help keeping the pressure within acceptable range. So these are the arachnoid villi. What are the risk factors? As shown by epidemiological studies, females are far more affected by intracranial hypertension if they are in the reproductive age group, if they have menstrual irregularity, if they have obesity or recent weight gain. Now, in conclusion, for the idiopathic intracranial hypertension, it predominantly affects females. And it is not benign intracranial hypertension because it may lead to blindness. The diagnosis is by positive identification of raised intracranial pressure through a lumbar puncture and by exclusion of other causes like cerebral venous thrombosis, which is treated differently. Cerebral venous thrombosis is treated with anticoagulation, while treatment for the idiopathic intracranial hypertension is by diuretics or by drainage through repeated lumbar puncture or lumboperitoneal shunt. Levels of treatment available according to the severity or refractoriness of we either can just give diuretics such as Diamox, carbonic anhydrase inhibitors, or we can go to repeated lumbar punctures, or at maximum, we can take the patient to surgery and insert a lumboperitoneal shunt. I think this is the last slide. I'll be happy to answer any questions you have. Any questions? We have 30 chats.
Doctor, can you repeat the delta sign for the cerebral venous thrombosis?
The delta sign?
Yes.
The delta sign, it's nothing but, you know that the sagittal sinus is a triangular structure, right? It's like a prism. It has the base at the skull, at the inner table of the skull, and then there is the peak of the triangle at the falx cerebri. So when you look at it, if you give enhancement to the tentorium and the falx, and the walls of the sinus will be dense, will be denser than the clot that is inside. So you find that there is a triangle, the triangle with a hollow inside, which shows the clot. And that's why we call it the delta sign, which means that there is no blood flow inside that sagittal sinus.
Thank you.
Okay, thank you. Someone is asking about osmotic edema. Osmotic edema, I mentioned it. It frequently happens in patients who undergo dialysis. And sometimes the dialysis, if it is done aggressively, they remove a lot of electrolytes from the circulation, in particular potassium, because it accumulates, and also some of the sodium. There is a lag of time between the equalization of the intracerebral electrolytes and the serum electrolytes. So at that time, there is a gradient. There is a more electrolytes inside the brain, and that may draw some fluids from the circulation inside the brain and cause edema. So that's called the osmotic edema. Okay, about the vasogenic edema, usually when there is disruption of the of the blood-brain barrier, I mentioned the example of malignant tumors. Malignant tumors grow faster than the blood vessels that require some time to be well lined from inside with the endothelium. So the endothelium will be defective. So inside the tumors, we know that there is what we call neovascularity. And neovascularity is vessels with imperfect structure. With imperfect structure, you get leakage. That's why when you give in CT scan or in MRI, when you give a contrast, such as the contrast of the CT scan or gadolinium in MRI, it leaks. That's why it stains the tumor. Now, the same phenomena happens that also the fluid and proteins from the plasma will leak outside these blood vessels and accumulate in the brain and cause edema. What intracranial contents can we remove? We talked about it. The CSF can be displaced, it can be absorbed and sent to the general circulation. Then the blood vessels can be compressed, so the total cerebral blood volume may be reduced. These only account for about 20% of the contents, and you can remove probably about half of them. So it will compensate with about 10% of, of the total volume inside intracranially. If the mass is higher than that, then it cannot be compensated for. Decrease in CO2 will cause vasoconstriction, yes. The papilledema and the circle, the papilledema, typically you see the periphery of the papilledema, which is the blurred margins of the disc. And they are bulging towards you, and we measure the papilledema by how many diopters you have to change on your ophthalmoscope between the surface of the edge of the disc, which has usually some capillaries you can focus on, and the retina that is surrounding. And that's why some people may say that this is a 2-diopter edema, 3-diopter edema. They can give it some kind of numerical type of intensity. Okay. Can we repeat the MRI interpretation of the diffusion-weighted and cytotoxic edema? Yes. Diffusion-weighted image is a special sequence. When they give you the radiology lecture, you will learn more about it. But diffusion-weighted image shows us the ability of the fluid to move from one side to another. As you know, across the cell membrane, there is a exchange of fluid and exchange of electrolytes. If there is some disruption, then the fluid comes inside the cells, be it astrocytes or neurons, and because it's swelling and it does not show diffusion. It doesn't diffuse outside. That stasis will be shown on this type of technique, which is diffusion weighted image. On the standard images, it will show white. If you do the mapping of the apparent diffusion coefficient, which is said ADC, it will show it as a dark area because there is no signal from the ADC map. I think these are all the questions that are in the chat. Okay, if there are no further questions, I wish you good luck. We will conclude the lecture.
Thank you, Doctor. Thank you so much.
You're very welcome. I'll send you the slides.
Thank you, Doctor.